Good afternoon, CVB team. I told you that I will share with you a lecture about aortic aneurysm, and I thought that the slides which we have for the aortic aneurysm, especially, is might be very limited. So I said, okay, I will try to share more slides related to the aortic problems, including aortic dissection and aortic aneurysm, because they are related to each other. And then after that, we will go back to our slides for the lecture slides. Okay, so right here, let's look at these slides. Okay, we have here the aorta. Okay, and you can see this aorta should be as one unit, but you have seen here like there is something which lead to a dissection. So this is a true lumen of the aorta now, and this is a false lumen of the aorta. This is like CT angiogram. So they have injecting like a dye into the aorta, and they try to take a picture using a CT scan. Okay, so you know that the aorta has different parts. We have the ascending aorta, the arch of aorta, and the descending aorta. And also the aorta has different layers. So the intima is the most inner layer, which is in contact with the blood, and then the media, which is the middle layer, and then the adventitia, which is the outer layer. Okay, when there is aortic dissection, what is happening that the dissection is a tear in the intima layer, okay, and then the blood dissects the intima from the media or goes between the intima and media. Okay, so when if this happen and the blood goes between the media and intima layers of the aorta, what will happen next? You will see like there is a propagation of blood either in this direction. The heart is here. Okay, so blood enters the dissection plan, or into this direction where is the abdomen is here. Okay, so either spread proximally towards the heart or distally toward the abdomen. Okay, and this will disrupt the blood flow to the vessels, as we will see. Okay, so there are different types of dissection of the aorta. Type A involves the ascending aorta and the arch of aorta, and these, because the heart is here, the heart is connected, and this is here's the aortic valve. We know that this area is under too much pressure or too high pressure, and this is should be treated surgically. This is the only treatment available. Okay, and then the descending aorta is not flexible like or elastic like the arch of aorta or the ascending aorta. Okay, and usually if the dissection happening in the descending aorta, it would be treated medically, because surgery is very hard for this part, and usually it is fatal. And with controlling of medical treatment means controlling of the hypertension and other problems which can lead to the dissection of the aorta. Okay, surgical mortality is very high for surgery involving the descending aorta. Okay, so the symptoms, what the patient will say. Patient will say, okay, I have a tearing chest pain radiating to the back. I have a tearing chest pain which is radiating to the back. Okay, other symptoms, with the propagation, as we said, of the blood of either to the aortic root, for this area, if this area is dilated, this side and this side, what will happen? The aortic valve, which is here, will be affected. So we will have aortic regurgitation. Okay, and the pericardial, we have the pericardium around the heart, which is two layers. Okay, blood will go in between, so there will lead to pericardial effusion or a tamponade. Also, we will have some sort of myocardial ischemia. Okay, and especially because these coronary arteries are branches coming out of the aorta. So especially we will have obstruction of the right coronary artery, okay, at the right coronary artery origin. If this propagation happens, to the aortic arch here, okay, and especially in this area, after the branching of the left subclavian artery, what will happen? It will affect the blood supply going to the carotids, and this will result in might possibly result in a stroke. Also, it can affect the thrombocytic chain and lead to Horner syndrome. Okay, or it can lead to a compression on the vocal cords and cause vocal cord paralysis. Okay. Anyway, we know that the recurrent laryngeal nerve, which is a branch of the vagus nerve, and the vagus nerve is the 10th cranial nerve, supplies the larynx and the voice box. So if there is aortic dissection affecting this area, or there is massive left atrial enlargement, and the left atrium should be around this area, it will lead to compression of the recurrent laryngeal nerve and will lead to what's called vocal cord paralysis. Okay. Other findings: blood pressure different between both arms. If you check the blood pressure, for example, in the right upper extremity, it could be 180, and in the left upper extremity, it could be 100. So why this massive difference between the right and left side? This is one of signs and symptoms of the aortic dissection. Also, if you have an X-ray, you will have like a widened, you know, mediastinum on chest X-ray. Okay, so the diagnosis is by taking history, like the patient will tell you, okay, I have, usually they go to the emergency room or to the ER, because the patient will tell that I have a tearing chest pain, which come all of a sudden, okay, after that by examination and chest X-ray, and this is the role of the physician. But the definitive diagnosis will be by CT scan or MRI, okay, or the TEE, or transesophageal echocardiogram. This goes through the esophagus until it reaches to the left atrium, and because the esophagus is very close to the left atrium and to the aorta, and it can visualize this area, and they can know if aortic dissection happened or not. Also, one of the markers is D dimer. D dimer is a sensitive but not a specific marker. Um, and if somebody have aortic dissection, unlikely to have normal values for D dimer. So, what are the risk factors for aortic dissection? I just said that we have three layers of the aorta, which is the intima, the media, and the adventitia, okay, or the outer layer. This medial layer, or the media of the aorta, is responsible for the tensile strength and elasticity. Okay, and there are two key proteins responsible for that: collagen and elastin. So, with weakness of this medial layer, this what two possible complications could happen: either aortic dissection, which we are talking about now, or aortic aneurysm, which we will be talking about it later. Okay, and there are common aneurysm feature, usually or mostly you will have medial damage or damage for this layer, the medial layer, okay, or destruction. Okay. Also, we have what's called vasa vasorum. What is vasa vasorum? Vasa vasorum is a network of small vessels, primarily supplying the adventitial layer, which is the outer layer. Okay, and this supplies blood to the medial layer in thick vessels like the aorta, okay. So with hypertension, people who have chronic hypertension, they will have thickening of vasa vasorum, and this will lead to weakness of the medial layer, and this could lead later on to the aortic dissection or aneurysm, as we will see. Okay, so we need high tension in order to break the weakened wall. It is weak already, but we need a high pressure or high tension to break or dissect this wall. So requires tension on the wall, common in proximal aorta, near the aortic valve, high tension from blood moving out of the heart, okay, and this would be worsened by hypertension. So that's why we see that one of the medical management for this case is controlling of hypertension, okay, and requires weakness of the medial layer. And this weakness, as we just discussed, could be due to affection of the vasa vasorum, okay, and this will lead to reducing the blood supply to this layer and weakening of the medial layer. So it is all connected together. Also, this is will be seen in collagen disorder, which is genetic disorder, because we said that two proteins are responsible, collagen and elastin. So collagen could be one of them, and there are some genetic disorders related to, to collagen disorder, okay, as a genetic disorder. What else? Cystic medial necrosis. This is development of cysts and necrosis in the medial layer, okay, of the aorta. And this occurs in to mild degree with aging as we get older, okay, and will be more rapid with some conditions like bicuspid aortic valve. So the aortic valve, instead of having three cusps, will have two cusps only, or some genetic disorders like Marfan syndrome. Okay, and this will be mainly common in ascending thoracic aneurysms. It is not common in the abdominal aneurysm, but more common in ascending thoracic aneurysm, because we will talk now that we have two types mainly of aneurysm, thoracic and abdominal aneurysm. Okay, so for aortic dissection, aortic damage, mainly hypertension is the primary risk factors, atherosclerosis, thoracic aneurysm. Okay, means like somebody have thoracic aneurysm, and this it leads to aortic dissection. That's why I needed to explain what are the layers of the aorta in and what is meant by aortic dissection. Also abnormal collagen, like in Marfan syndrome or Ehlers-Danlos syndrome, and these are genetic disorders with collagen formation disorder. Others, we said bicuspid aortic valve, Turner syndrome, which is genetic or chromosomal abnormality in a female with 45XO. She has only one X chromosome. Okay, and in this case with Turner syndrome, she will have a bicuspid aortic valve also, and a case very famous called coarctation of aorta, which is like a constriction of part of the aorta. Okay, and this is tertiary syphilis. Syphilis is one of the sexually transmitted disease lead to aortitis. Syphilis was, a few decades ago was very common to be one of the main causes. But, now with the advances in treatment of syphilis and screening for syphilis, it is, one of the less important factors. So for aortic aneurysm, we will have now we finish aortic dissection. Now let's go to aortic aneurysm, which is the main topic of our lecture today. Or the main aortic aneurysm means dilation or bulging, dilation or bulging of the aorta, more than 1.5 the size of the normal size of of this of the aorta, of the caliber of the aorta. And it is true aneurysm, because we have sometimes we have false aneurysm and sometimes we have true aneurysm. So this is true aneurysm. True aneurysm means it involves all three layers of the aorta, which, as we said again, the intima, the media, and the adventitia. We have two types of aortic aneurysm: thoracic aneurysm, or TAAs, or abdominal aneurysm, which is triple A's. Okay. The thoracic aortic aneurysm, important risk factor for dissection. Some people who already had like thoracic aortic aneurysm most commonly will have aortic dissection if it is not treated, or it is not managed. Usually occur in the proximal and the ascending aorta, because these are high tension or high pressure area, as the heart is just here, usually seen in association with another disorder like Marfan syndrome, Turner syndrome, bicuspid aortic valve, or syphilis. Family history of aneurysm is important too because it runs in some families, may be associated with atherosclerosis, and this is important because we will talk about that later on. Most common in More common in descending aorta. Why? Because this is less flexible than or less elastic than the ascending and the arch, occur in association with atherosclerosis risk factors like high blood pressure, like smoking, like high cholesterol. Thoracic aortic aneurysm, the symptoms most mostly are asymptomatic. Mostly are asymptomatic. So somebody could have thoracic aortic aneurysm and it has no symptoms whatsoever. Can cause aortic regurgitation, okay, because the bulging or dilation of this area will lead to the aortic valve will be, incompetent, so there will be some aortic regurgitation here. And if this dilation is more than 5 centimeter, surgery is a must. Okay, so let's go to abdominal aortic aneurysm or triple A. This is more common than thoracic aneurysm, okay, and classically taught as a disease of atherosclerosis. It is infrarenal aorta most commonly affected by atherosclerosis. Almost it is, I mean, between at this area below the renal artery and before the branching of the aorta. Also most common site of abdominal aortic aneurysm in this area. Current research suggests many factors: genetic factors, environmental, hemodynamic factors, and immunologic factors. So for abdominal aortic aneurysm, as we said, it is more common with atherosclerosis. So smoking will be have a strongest association with abdominal aortic aneurysm. It is more common in males, 10 times more in males than females. And the age, it is rare before the age of 55, but it will be increasing for males above 65 years of age. That's why about 5% in men above this age might have abdominal aortic aneurysm. And that's why they do screening for abdominal aortic aneurysm for people at this age. It is associated with hypertension and hyperlipidemia as well. For abdominal aortic aneurysm, mostly as a thoracic aortic aneurysm, it is asymptomatic. Some detected on physical examination, like examination of the abdomen. There is a pulsatile mass from the void process of the sternum till the umbilicus, and we have a pulsatile mass. What is that? What's going on? Natural history is enlargement, and this enlargement could lead to rupture. So it is usually as a follow-ups with ultrasound or CT scan to see if the enlargement is dangerous enough. If this enlargement is above centimeter, then surgery is a must. Okay. The last thing is aortic rupture, usually from trauma. Most commonly site is this isthmus, this area. Okay, and uh, these are the slides which I bring to you. But let's go back and see our other slides, okay, from our presentation, mm, which will be important also. Okay, so aortic aneurysm. We have the two lungs, we have our heart, we have here the aorta is a major vessel, okay, and we have the both kidneys. See, this is abdominal aortic aneurysm bulging here in the abdomen, okay, and like Waking wall, fatty layer lining the aneurysm. Okay, so what is aortic aneurysm? A permanent pathologic dilation of the aortic wall that is at least 50% greater than the expected normal diameter. More than 3 centimeters is considered aneurysmal in adults, typically described in terms of location, size, morphologic appearance, and origin. Abdominal aortic aneurysm or triple A are most common. Okay, usually cause no symptoms. It is asymptomatic, like we said, except when ruptured. Okay, and occasionally abdominal, back, or leg pain may occur. Large aneurysms can sometimes be felt by pushing on the abdomen. We will see pulsatile mass. Rupture may result in pain in the abdomen or back, low blood pressure or loss of consciousness, and often result in death. Okay, so for aortic aneurysm risk factors, smoking, current or past, five-fold increases versus non-smokers. Age, most common individuals above age of 60 years of age. Gender, it is 5 to 10 times higher incidence in male than in women. Women with aneurysm have a higher risk of rupture. So it is more common in male, but if a woman have aneurysm, they have higher risk for rupture. Family history, first degree relatives has an increased risk. Hypertension, hyperlipidemia, atherosclerosis, these are all risk factors. So for um, peripheral arterial disease has also been recognized as a risk factor for abdomen or triple A or aortic abdominal aneurysm. In observational studies, the prevalence of AAA was higher in patients with symptomatic peripheral arterial disease than in the general population and in the population of patients with atherosclerotic risk factors. The prevalence of AAA among patients with peripheral arterial disease increased with age, beginning in patients over the age of 55 years of age, and was highest in patients over 75 years of age. Okay, so aortic aneurysm symptoms and physical therapy implications. Aortic regurgitation, and we explained why that. Pulsating tumor or mass in abdominal area during the examination of the abdomen. Broad heard over swollen area in the abdomen where you are hearing with the stethoscope. You will not hear the normal linear blood flow. You will hear like a broad. Chest, abdominal, back, or flank pain can be abrupt and severe at the same time. Leg pain, claudication pain, numbness in the lower extremities, excessive fatigue, especially with walking, poor distal pulses, low back or flank pain. And what is the physical therapy implication related to aortic aneurysm? Identify risk factors and the immediate family history in initial visit, because we said that first degree relatives could be a risk factor. Assess vital signs if there is tachycardia, low blood pressure, especially with patient complaints of sudden abdominal pain, could be a sign of rupture, because if there is will be internal bleeding, what would you expect? You would expect the blood pressure to be really low blood pressure, and at the same time, because there is bleeding, internal bleeding in the abdomen, as the blood is not going back to the heart, or the venous return is not good enough. So then the stroke volume will be low. So what the heart will be doing in order to keep the cardiac output as it is, the cardiac will work faster. So there will be tachycardia. Promote regular moderate exercise activity in these patients. Research suggests moderate activity individuals with a small aortic abdominal aneurysm does not influence risk of rupture. So that's it for the aortic aneurysm. I should be also, sharing with you another lecture soon, maybe today or tomorrow, about myocardial infarction. So please, look for that coming on the blackboard as well. Thank you so much for watching and listening for the lecture. And please, if there are any vague points or points which need further clarification, either reach to Dr. Bliza or reach for me, and we will try to explain to you as much as we can, because we are devoting all our time for your success and for getting a very good result this semester and after that in your studies. So good luck and best wishes. Thank you.